Welcome everybody. Thank you very much for coming along today. It's great to have you all here. We're at 63 people thus far, but we've got plenty more people that are supposedly going to join. We're at 12 o'clock, so we're going to make a start. Just before we jump into it, just a couple of housekeeping points. Aside from those that are presenting, you'll notice that your camera is off and you're muted. And that's just to make sure that the audio experience for everybody is as best as it can be. We're going to try and keep it to an hour long, and there will be a recording available at the end of it that will be circulated to everybody that's registered. So as we go through the session, obviously questions are going to come up. If we can use the Q&A tab at the top here rather than the chat function, at the end we're going to loop back and answer all the questions in one go. So make sure that you keep popping that in there and we'll answer those at the end. So first up, I'm Grant Woodcock, the commercial manager here at Felgains, and we are delighted to be hosting this webinar, Unpacking the Enhanced Health and Care Homes Framework, and specifically focusing on exploring falls and falls best practice. So as an organisation, Felgains, we're hugely passionate about post-falls management, and we work on a lot of projects to upskill care staff, I guess, effectively, to be able to assess and respond to fallers rather than having to call an ambulance. Now, we believe and have a vision that it's entirely possible to eliminate ambulance call-outs to minor and non-injury falls. Now, not only is that a possibility, but we believe it's an imperative, kind of given the challenges, the pressures that are on the system at the moment. So with this webinar today, we've got presenters from quite a wide variety of backgrounds, and they'll introduce themselves in due course. But what we're trying to do in this specific webinar is, obviously the Enhanced Health and Care Homes Framework is quite a broad document, but there is a section in there around falls, and what we've tried to do is pull on different partners across the country that are pioneering the way and doing excellent projects that specifically relate to those pieces of guidance. So in a minute we'll be hearing from Emma Self from NHS England, who's going to be giving us an overview on the Enhanced Health and Care Home Framework, and then Lisa Cooper and Doug Reed are going to be talking to us about the work that Oxleas have been doing, engaging an MDT team in proactively identifying the falls risks and then proactively managing that. And we've got sorry, I meant to say before that, we've obviously got Pip Logan as well, Professor Pip Logan from the Nottingham University, giving us an overview of the Action Falls programme. And then finally, we've got Vicky Dyer and Mandy Steele that we're going to be going over what Cambridgeshire and Peterborough have done in successfully implementing post-falls assessment tool and lifting devices to care homes. And at the end of that, I'll do a quick overview of Helpful and then a live demonstration of using the Razor chair. So without further ado, Emma, over to you, and give us a bit of an overview of who you are and what you're going to be talking to us about today.
Thanks very much, Grant. So hi everybody and welcome. I'm Emma Self. I'm Delivering Policy Lead for the Enhanced Health and Care Homes programme with NHS England. So I'm just going to give you a bit of a background to the programme itself and then sort of lead into the priorities we've got for the programme for this year from the national perspective. So if we can jump to the next slide, please. If you've not heard of the framework before, it's been around for some time. Back in 2014, there were 6 care home vanguards across the country who all sought to do the same thing, but they went about it in different ways. So essentially, they were trying to prevent unplanned admissions for care home residents, make best use of resources, and ensure that residents receive care in the place that they preferred, which is generally not in the hospital setting. So the first framework was published in 2016. It was published at the time as best practice, and commissioners across the country took up parts of it, but not necessarily all of it. And then in 2019, there was a recommendation in the long-term plan, or a commitment, I should say, in the long-term plan, that the EHCH programme would be rolled out to all care homes across England by 2024. So it started in 2020. So way back in 2019, we started to refresh the framework and then published version 2 of the framework in week 2 of the pandemic, so no fanfare whatsoever, but there were contractual requirements in the framework, both in the primary care network direct and enhanced service, which essentially is the GP contract, and in the NHS standard contract, which is what commissioners use to commission their community services to deliver. And so if we just jump to the next slide, please. The contracts then both detail the same thing. So basically, every care home across the country will be aligned to a primary care network. Every care home will have a named clinical lead that comes from within that primary care network, and that clinical lead is responsible for the implementation and oversight of the Enhanced Health and Care Homes framework. Every care home should be in receipt of a weekly home round or check-in by usually the GP or the clinical lead, and that's supported by a multidisciplinary team too. And then for residents specifically, within 7 working days of admission or readmission to a care home, every resident should receive a comprehensive assessment of their health needs undertaken by a member of the MDT. Now that will include care home staff, because obviously they comprehensively assess their resident on admission or readmission. Once that assessment has been completed, the MDT then also make personalised, proactive care and support plans for those individuals. The whole ethos of it is this about preventing unplanned hospital admissions. So most residents, if not all, older residents in a care home will have a number of long-term conditions. They will become unwell at some point in time and usually require hospital admission. Most often that is unplanned. What proactive care in care homes should be about is recognising that these people will deteriorate at some point in the future, proactively planning their care so that when they do start to deteriorate, the health and care services can act much faster and treat them in the care home rather than having an unnecessary hospital admission. There's also a separate part of the network contract for primary care which talks about structured medication reviews. Within there, it says that care home residents should be prioritised for a structured medication review. That quite naturally forms part of what would be done in the Enhanced Health and Care Homes home round. So looking at an individual's medication, making sure that the medications they're taking are still fit for purpose and they're actually not harming the resident. Quite often people are on a lot of medications when they're in a care home too. If we just jump on to the next slide, thank you. So in 2022, we sought to update the framework, primarily because a lot had happened during the pandemic. And the recognition that what happened within care homes meant we had to change significantly the way we interacted with care home staff, with care home residents. What was great about the way we had to work together was a lot of the barriers that previously existed simply fell away and people worked hard together for the interests of the resident. So what we wanted to do with version 3 of the framework was to recognise at this point it was sort of 2 years post-publication and the pandemic had happened in the meantime. Things like NHS Mail, pre-pandemic, there was about a 10% take-up nationally of care homes using NHS Mail. When it was mandated during the guidance that was, or the policy that was published very early on in the pandemic, it was mandated that care homes should have access to either NHS Mail or another secure email. That shot up to over 70% within about 4 weeks, and we simply would not have achieved that without the conditions imposed on us through the pandemic. So we wanted to make sure those ways of working and best practice were encapsulated in version 3 of the framework. And we obviously use digital enablers in a far greater way than we ever have before. The focus in the previous framework on the personalised care and support planning wasn't as strong as perhaps it could have been, so that's been strengthened within this framework too. And then we've included a subset of health and wellbeing dimensions, which I'll talk about shortly. With version 3 of the framework, we engaged with over 500 stakeholders across health and social care. So it really was a phenomenal team effort in putting this version of the framework together. What we like about version 3 is it's far less jargonistic, it's far less policy speak. It's hopefully much more simpler to read for people too. So if we just jump to the next slide. The focus then, or the clinical focus within this framework particularly. Now this isn't an exhaustive list. We originally came up with a document that was twice the length. but it looked like it was becoming more of a cookbook than a framework. So we were advised to strip that back. We can't publish anything generally above about 20 pages. So we stripped out the things that were cluttering it up and made links to them elsewhere in the framework. But these are the really key things that we need as a system to support care homes to address. And the responsibility lies on all of us across health and social care. This isn't one person's remit particularly. But the key focus for us for this coming year has to be a recognition that falls in care homes can have a significant impact on residents, but also on the staff that care for those residents too. So one of the key priorities for us is going to be looking at falls and how we can help care homes to prevent falls, or support care homes to prevent falls in the year going forward. So if we just move to the next slide. Some facts and figures here. I know Pip will talk in a lot more detail about falls in care homes, but it won't be a surprise to recognise that everybody in a care home, in an older person's care home, would be classified as having some degree of frailty. So the chances of them falling in any 12-month period are already significantly higher, but the really alarming facts are you're 5 times more likely to fall if you live in a care home. If you have dementia, which estimated up to 70 or 80% of people in a care home have cognitive impairment, you're 8 times more likely to fall or have an incident relating to a fall, and you 10 times more likely to suffer a serious injury. I don't need to read through the details for you. So for us as a programme, the question to ourselves is, why wouldn't we have a focus on falls? It's one of the biggest reasons residents from care homes get admitted to hospital, and is, to some extent preventable. Again, Pip will talk about this in more detail. We're not suggesting that every single fall is preventable. They simply aren't, but a lot of them could be. So I'm going to hand back to you, Grant, and then lead into Pip. Thanks very much.
Thanks, Emma. That's excellent. No doubt there'll be a few questions for you to pick up at the end. Yeah, thanks. Go for it, Professor. Pip, over to you.
Oh, thank you. Thanks. Can you hear me okay, Grant? Yeah?
Loud and clear.
Yeah, brilliant. So thank you very much for inviting me to come and talk on this, and thanks, Emma, for that run-in. I am a professor of rehabilitation research at the University of Nottingham. I'm also an occupational therapist who works clinically in the Nottingham city area. So I've had a lot of experience of people falling over, and I got involved in the research in this about 20 years ago when we were working with a group of care home staff and residents and families and social care and NHS staff who were worried about the falls of residents in the care homes. So if we move on to the next slide. So this is really just going over what Emma's already said. We know there's a lot of people living in care homes. We know there's a lot of people having falls in care homes, and we know a lot that actually that can create that fear and anxiety in the care home staff. And so 20 years ago, when I was asked to get involved in this intervention, Action Falls, which we're talking about, was developed and co-created by care home staff. It was the care home staff who brought the ideas to the group, and there's care home staff in all of our publications, managers. Sometimes we even get care home residents. So although Emma said 80% of people have severe cognitive impairment, that does leave 20% of 421,000 people who can take part and come to meetings and contribute and present data and come to conferences and really take part in the research. So we've made a big effort to make sure we've been co-creating everything that I'm going to present to you today. So if we move on to the next slide. So what is Action Falls? Well, Action Falls 20 years ago was called the Guide to Action to Prevent Falls in Care Homes. So if you've heard of the Guide to Action, this is its new name, Action Falls. And so we're moving forward with Action Falls. The reason we changed the name was because care home staff said to us, well, the Guide to Action to Prevent Falls intervention, the name's too long. And when we're talking to other care homes, when we're talking to families, when we're talking to GPs or primary care staff, we want to be able to say we're using something, and we want, and Action Falls is easy to say. So we went with the Action Falls. It changed a couple of years ago. The actual principles of the intervention are still exactly the same. The idea is that we go through a checklist looking for risks that are all evidence-based. All of the work we've been able to publish, we've been able to get it into clinical guidelines, we've got BMJ articles, and we can, the references are all on the slides, so you'll be getting them. but just to show you that this was actually all the way through, has been fully researched. So basically, we have a checklist where people use evidence-based to find the falls risks, and then we have ideas about actions that people can take. So it's the actions that people take that get the good results. And later on I'll show you that the trial showed that falls in care homes can be reduced by 43%, and that was the biggest trial in care homes ever completed, and we did it again with the care homes across the UK. So these are the manuals that we have. Obviously, if you're going to use a new intervention, you need to be trained in it. The training is a 1-hour training program, and we've worked out that if you train everybody in the care home, that's really good. So the cleaner, the caretakers, the gardeners, the cook, family members, residents themselves have all come to the training sessions. The training session at the moment is a face-to-face activity because care home staff have asked for that. But obviously going forward, we're looking at working with NHS England about how that could be rolled out so it could be quicker, or maybe part face-to-face, part online, with support sessions. We know that people once trained need support sessions. We have an app that goes with this. We have a website that goes with this, and we have a toolkit now that shows the return on investment, that if you invest in action falls in your area, that how much money you'll be saving by reducing the falls rates and reducing hospital admissions. I've just put on the bottom that in these studies we've been using the World Health Organization's definition of a fall. So we could move on, please. Oh, we got stuck. Oh, there, brilliant. So these are some of the main papers that we've been doing over the last 20 years. So in fact, it's longer actually. 2012, Kate Robertson, who was a falls lead for the Nottinghamshire area, published Thinking Falls, Taking Action. You can still get this, you can still download it, free access. And then we went on to do a feasibility study, which is in green, funded by the NHR. And then we went on to the big one that's in sort of a turquoise colour. We went on to the big multi-centre trial, which was published in the BMJ. And the paper below that is the big HTA report, which is 80 pages long. So have a look at the BMJ abstract first, and then if you want to know any more minute details, go to the big HTA NHR's journal article, which is below it. In between, we've been looking at how we can do our apps. We've been looking at how we can use what we've learned in learning disabilities, in hospices, in people with Parkinson's, in people with strokes, and we are going on further to do more research. So you know, it's not an ended program here. We're constantly updating and making sure it's evidence-based. So if we go on to a little bit further. So just a little bit about the trial for the people who are academic in the audience, just to show that when you go to your commissioning panels, you can say this action falls has been totally rigorously researched. We ran the intervention side from the Nottingham University, but it was all, the data was all collected by the University of East Anglia, which gives it that distance and gives it that rigour. It was a randomised controlled trial, so the care homes were randomised. There was 87 care homes. We did a full process evaluation and a full economic evaluation. We had a really good return on the care home data. And if we go on to the next slide. These are the sites we were using. You can see the names of the sites on the right hand side. You can see the recruitment rates going up on those graphs. And this really is just showing you this to show that the care homes themselves were really keen to take part. And that shows to me that if they're keen to take part in research, they're obviously keen to address falls. Because taking part in research is an onerous task. It's quite a commitment for your staff to take part, but they did. The rates went up, and we could have carried on recruiting higher and higher, but we ran out of money. So over 1,000 care home staff took part. That's interviews, collecting data, you know, really good engagement. You know, 1,657 residents. Obviously, some of them couldn't give us consent. We had to get consultee consent for that. But we've collected a lot of data, and just to highlight how much data we've got, and we are in the process of sharing our data with people who want it. We have 20,000 medication events recorded, Some of these people were on 13, 15 medications, and we've collected all that data. So it's useful for other studies as well and other evaluations, having this big data set. So the next slide. So these were the results from the trial. As I said, we had the care homes that used the Action Falls programme had a 43% reduction in their falls while they were using the programme. It was relatively cheap. And when we look at it, we do our comparison of cost against other interventions like hip replacements and medications, and it's actually come out as one of the interventions that NHS England would be happy to support because of its economic evaluation. As I said, it's a 1-hour training programme for care home staff. Most care homes have been very happy with having a 1-hour training programme, and as I said, they did prefer the face-to-face. There's a nice infographic that you can download. We've got a PDF of it as well if you needed to show it to anybody, just with the results in an easier version than the BMJ paper and the HTA. So if we just go forward, what we're doing now, so that trial finished in 2021. We've now moved on to how we implement Action Falls across the UK. Well, actually in England at the moment. We're doing a study at the moment, just about to finish in September, with 60 care homes across 4 localities. And in these care homes, each localities had falls leads who have usually been supplied by one of the NHS trusts or a social care organisation, or sometimes the care home companies themselves have provided the falls lead to come to training. Then they've done a train the trainer level, so then they've trained the care home staff. And again, 80% of the care home staff have been coming to the training from all levels of the care home community. We've been running quality improvement collaborations so that care homes can talk to each other about how they use Action Falls. And we've been collecting questionnaires and interviews because we're a research team and we like getting the research, collecting the data and then publishing it and then disseminating it. And we've been collecting the number of falls recorded in the care homes. Now, in the big trial, we collected them from the care records. So we literally went through every care record, every line written mostly on paper in those days, and collected when a fall. But because this was an implementation study that we're doing now, we collected it directly from the care homes. And so each care home had to set up a process of how they were going to record the falls and send them to us. So if we go on to the results of this study. So again, really good engagement from the care homes. 663 care home staff sending in questionnaires. 80% engaged with the training. They showed coherence and collective action. Collective action is where groups of people get together, talk about things, come together to try things out together. As you would expect, the new intervention, it's a bit of embedding in the place. And cognitive participation is when people engage with their brain. So they're thinking about it, they're talking about it at home, they're thinking about it maybe for their own relatives. Oh, Action Falls, maybe we could try that with our own relatives at home. We collected the falls data. The care homes were brilliant at collecting the falls data. 5,829 falls recorded. We're still getting a lot of falls. These are care homes that were trained in Action Falls, and we're still getting a lot of falls. One of the things we said with Action Falls, we do not want people to be restricted in their activity. We want them to carry on. And we found more falls in the care homes where they did not engage with the Action Falls training. So I think our last slide, going forward. So just in conclusion, I really do believe that care home staff are crucial. They're crucial to the research, they were crucial to making the intervention, and then they're crucial to engaging with the intervention and that in the broader sense of care home staff. Going forward, our next job is to make sure that Action Falls needs to be embedded in the existing electronic systems or the new electronic systems people are bringing out. And we're working hard with those companies to make sure that it's in there. We know that the training for the falls leads in your areas and for the falls leads in the care homes and the care home staff is essential, and that's ongoing support is needed if people are going to keep things up to the level that they were able to do in the randomised control trial. And we've been able to find and prove that falls are reducing the falls are most effectively reduced when the care home staff are engaged and have confidence in being able to use the action falls. So I will stop there, Grant. I don't think there's another slide, and I'll have questions and answers. I think they're in the chat. We're going to do them later. So thank you very much.
Thanks, Pip. Excellent. Just on that, yeah, there's a few questions popping through, which is good. There is one there from Sue Dorling, Pip, that you might want to take rather than doing that publicly, but you can type your answer in there, but keep them flowing, it's really good. So now we're going to hand over to Lisa Cooper and Doug Reed, who are going to be going through the MDT piece, work they've been doing with the PCN. Over to you.
Thanks very much. So good afternoon, I'm Lisa Cooper, Associate Director for Bexley Physical Health Services within Oxleas, and my colleague Doug Reed is Service Manager, and will be presenting some of our work around falls training and falls clinics in our local care homes. So next slide, please. Just a little bit about Bexley and where we are. We're in Southeast London, on the border with Kent. We have 3 local care networks. We work very closely with our PCN leads around wider service development, so that neighbourhood working is quite well established. We have 1,300 care home beds, and we've given a little bit of a breakdown there in terms of dementia and general nursing beds, etc., just so that you can see the breadth of which our teams are supporting care homes. And we are ranked 3rd in London for the highest over 65 population. So we really needed to think carefully about how we responded with our service provision to that population, but also to those in care homes. So next slide, please, Terry. So our complex case team was established in June 2020, and at that point in time it was a manager at 8A level, a clinician by background, and an administrator with the purpose of really thinking and bringing together partners to support those residents in our care home. We were looking at LAS conveyance data, hospital admission data, getting feedback from our care home staff and our primary care colleagues. And so as a group, we felt that having a focus and a way of coordinating that care together and all of those needs would be really important. So we were focusing on those residents in our care homes at highest risk with the most complex needs. And I think, as Emma alluded to, the COVID pandemic cemented that working relationship. It was very challenging for our care homes. They really valued developing that relationship with our complex case manager, Suki, who is on the call today, and as a point of contact to really help them navigate a really complex and worrying, frightening situation for them. We very quickly saw some system benefits around reducing our ED presentations. As I said, the relationships really developed. And so we have sought to increase our staffing in that complex case team as funding opportunities have been made available to us. So next slide, please. You can see here that team has increased significantly. A lovely picture of some of our staff there as well. And what this has enabled us to do is to set up virtual MDTs with all of our care homes. We've also recently expanded that to some of our reablement providers as well. And all the things that Emma alluded to in the guidance is what we are following in terms of managing early identification, working with lead GP, providing complex health and social care support to those residents, and a real focus on training our care home staff in relation to falls prevention and giving them the skills and technique and the confidence to manage those residents to prevent falls, which we knew were quite high level in our particular area because of our population. So Doug will take you through what we've actually been doing.
Thank you, Lisa. So in 2020, on sort of the inception of the service, our lead occupational therapist reached out to the Scottish Care Inspectorate and NHS Scotland to get consent for us to use the Managing Falls and Fractures in Care Homes for Older People's Good Practice resource. So that was fantastic. We did a lot of good work together, and we were obviously allowed to use their resource, which enabled us in 2021 to devise our falls prevention and management assessment tool. Obviously, working as part of a system, we presented this to partners including the ICS, our quality assurance team within the London Borough of Bexley, primary care, and indeed our care home forum, which runs monthly in Bexley. So that assessment tool really helped us to work with the care homes to identify and highlight gaps in falls training within each care home, the policies and procedures that they did have in place or things that needed to be put in place, the environmental issues that they experienced, and the current assessments being undertaken by the interventions within the care home. So it really enabled us to open up and really look closely at the different gaps and areas that we could be working closer with the care homes. So next slide, please. Following looking at the areas that needed to be developed to what we could work with the care homes we implemented a falls toolkit with each of the care homes, and then subsequently as part of that implemented the FinCH training, and that was undertaken with all the care homes and continues to be weekly, and we enable weekly slots for each of the care homes to book in for us to implement and undertake the training with them. There have been some challenges, as could be expected, particularly obviously during COVID and subsequently as well, just often with maybe high turnover of staff rates within care homes, but also enabling the staff to be able to have their time freed up to actually attend the training. So both the ICS and the London Borough of Bexley Quality Assurance team really helped us work with the care homes to support the implementation of the training, and particularly maybe as some care homes were experiencing certain issues that were leading to more falls, to enable us to work closely with them to really support them and indeed free the staff up for obviously to help with the challenges that they were facing. Just here, just to sort of put things into context again, Lisa's already mentioned that Bexley is the third highest with a population of over 65 in London, and we've from some of the LAS data, we can see that over 8% of population within Bexley were fallers over 65, and in conjunction with the care homes, that actually came out as 17% of incidents were relating to falls within care homes. So it was quite clear within Bexley, obviously falls are an issue, as we know that are an issue across the piece, but something obviously really that we felt was obviously identified and appropriate for this piece of work for us to continue. So actually, if we can have the next slide, please. So as an aside, obviously, to the actual falls training that we undertake, we also run falls clinic, and we have 2 clinics per week for all the care homes. And the patients are identified for these for the clinics in a variety of ways. One being as Lisa alluded to, the MDTs that we hold, where we have many different staff involved, including the lead GP for each care homes. So we can identify patients from that, also direct from the GP or indeed from the quality assurance team. We also do receive weekly data from the care homes. We set up this process so that we could actually have weekly data so that we could look and monitor any anomalies, or if there were certain residents that were experiencing specific falls or specific reasons, and again helping us to maybe look at trends as well, so we could really focus on the needs of each individual care home. There is no referral that's required, and all the therapy, the clinics are all therapy led face-to-face within the care home. So our key focus for the falls clinics is looking at those individuals who've had 2 or more falls within the last 6 months, those with fear of falling, which is obviously so prevalent and very, a very high thing for a lot of individuals with their actual fear of falling. Unexplained falls, where apparent complex medical issues or causes, we need to establish loss of consciousness. I think as Emma already mentioned, I think as well as Pip, the complex medication issues that are often experienced, and any other medical investigations that may be required or haven't occurred, and we can see those resulting in sort of dizziness and vertigo and other presenting issues. One episode of a fall that's led to a hospital admission and indeed injury, new or worsening gait and balance defects. So those are some of the kind of key areas. I think as well with our population within Bexley, we have such a high population of frailty. So again, lots of comorbidities, and indeed a lot of these issues are prevalent. So next slide, please. So this is just a case study, and I think it probably does pick out quite a few of the things that we've all been sort of alluding to here. So I'll try and run through this quite quickly, and I'm conscious of time. So this is about an 83-year-old female who was diagnosed with dementia for the last 15 years. She's been living in the care home for 4 years. She's had 3 hospital admissions in the past year due to physical health issues, including sepsis, infection and dehydration, and was unfortunately experiencing multiple falls on a weekly basis. So our input was, she was reviewed in Falls Clinic, and we found her communication was quite difficult. She was quite non-communicative. There were unwitnessed falls. She was always being found in the corridor or the lounge, and general lethargy due to constant pacing and loss of weight. So some of the actions from the Falls Clinic, blood showed she was pre-diabetic, so we initiated a dietitian input, and she also had low vitamin D. We introduced meaningful activities based around past hobbies to reduce the pacing, and it was found that this lady had a history of really enjoying singing. She was into sort of amateur dramatics as well, so we used a lot of those meaningful activities with her. Medication was reviewed, and her risperidone was reduced. And obviously, we all understand that sometimes those types of medication, antipsychotics and risperidone, etc., will and can lead to some of those falls that we talk about. Advice given to staff and management, including supporting her to take regular rest periods and naps. So the outcome was she was more alert and settled, better nutritional and fluid intake. Her pacing reduced, and there weren't any falls between her second and third clinic appointment. The staff notably saw her after her singing. She was much more settled, so that was really, really positive, and it's really nice to actually access an activity and reminisce as well with her as part of her treatment programme. She was less dependent on staff and better engaged with other residents, so a nice positive outcome, and a case where we really did try and make the care as individualised as possible. Next slide, please. So this is just to briefly look at some of the partnership achievements that we've had since we started the team. So we've had a total of 186 patients assessed. In our clinics, we've managed to train over 400 care home staff in Falls training. We've managed to get Falls champions implemented in every care home, and again, that can be a challenge in itself due to staff turnover, but that's a success as well. In our first year, we had an 11% reduction in conveyances in year 1, and obviously that may, again, in relation to COVID as well, that needs to be taken into consideration. Within Bexley, there was a monthly care home forum, and the team present, and that includes the ICS colleagues, GPs, and indeed every single care home in Bexley as well. So it's a great opportunity of system working and learning, and a way to communicate really effectively and share some of that learning and the challenges across the system with the care home teams. And we have our rolling weekly training programme as well. So I think our next steps, as we've all said, is to keep learning, keep sharing, keep supporting, because I think, as Lisa said, that was a huge element, particularly during the pandemic, where care homes really felt very siloed, and they really appreciated the support that we were able to give. It's important we all work together as equal partners, and I think being able to be transparent and sharing that learning, sometimes even if that learning can be challenging. And also, I think, as others have alluded to as well, develop a wider data set to evaluate our impact. I think that's probably it from me, so thank you very much.
Thanks, Lisa. Thanks, Doug. That was excellent. The case study kind of helps to bring everything we're saying to life a bit better, doesn't it? Okay, right. Well, let's keep moving because we're running a little bit tight on time. So, Vicky and Mandy, over to you. Tell us about what's been happening in Cambridgeshire.
Thank you, Grant. Thank you for inviting us. I'm Vicky Dye. I'm Project and Service Improvement Manager here at Cambridgeshire and Peterborough ICB. I work specifically with the Nursing and Quality Directorate in the care home team, hence this project, and I'm supported by Mandy. I'll let Mandy introduce herself.
So, hello everybody, my name's Mandy Steele. I've recently joined the ICB as the Clinical Quality and Patient Safety Lead with specific focus around care homes and domiciliary care. So real excited to be of support to this project work.
Thank you. Can we have the first slide, please? Okay, so this project was to install falls lifting equipment specifically supported by a training app and algorithm into a selection of nursing homes across Cambridgeshire and Peterborough. The lifting equipment went into the homes starting in February 2023, and we finished the project in December 23, although our data cut-off was October 23. The care homes were chosen via the data that we got from the ambulance service, and we looked at data from the previous 6 months and chose the homes that had the most falls. We designed some spreadsheets that went out to the nursing homes, and that data was collected monthly and sent in to us. And just to ensure that you're aware that the project supports post-fall management, not falls prevention strategies which are being addressed within the wider services. I need to mention that initially this project was set up for 10 care homes, and we were really lucky to obtain some extra funding and were able to extend that out to additional homes. So the aims, you can read those, but I'll briefly flick through them. So improving the quality of care for residents and their dignity, reducing adverse consequences of long lies, empowering care home staff, reducing care home staff attending the faller, releasing ambulance resource, reducing calls to 111, reducing hospital emergency attendances, admissions and those associated costs, and reducing pressure on the acute and emergency services. Next slide, please. So our approach, initially we started with 10 care homes and we added a further 32. So we demonstrated to 42 care homes. Let me explain that. We took our lifting equipment out to every single one of those 42 care homes. We had demonstrations from both Manga, Wincare who provide the Manga chair, and Felgains who provided the Razor chair, and we both of those companies, assisted by our staff, went into 42 care homes and demonstrated the lifting equipment to the staff within those care homes. And the objective of that was to make sure that their care home staff could really touch and feel and get a sense of how that lifting equipment worked, and it would enable them to make a real informed choice about which equipment they would like to run within the pilot. The post-fall assessment apps support their care staff to identify when it is safe to lift the resident from the floor. And the project was initially supposed to run for 3 months. And after 3 months, we reviewed it, and it was really clear that the changes were not going to be embedded in the care homes within a 3-month period of time. So we extended it out until the end of December, the end of December 2023. The care home team after that first 3 months worked alongside the lifting equipment companies to further design a specific training resource that was demonstrated to the care homes as additional support. Next slide, please. So this is the Manga cushion, and the Manga ELK is on a lot of the ambulances in the UK. It can be used in multiple positions to lift from the floor, sitting or laying flat.
The staff reported that it was comfortable, they felt secure when they were lifted, easy to clean and lightweight. And the next slide, please. And this is the razor chair, which I know Grant is going to demonstrate later. The benefits to the razor are that it's quick and easy to use. There's no need to move the resident at all. You can assemble it around the resident. It's sturdy and has the seat belt for added security. It's a one-person operational system as well. Next slide, please. So these are, I hope you can see that. These are the post-fall assessment tools. So the Helpful is the one that we use with the razor chair, and the iStumble is the one that is used with the manga chair. So Helpful was developed during the project, and it now includes a dashboard that we can log into, and that dashboard gives us monthly data, which is broken down to major, minor and no injury falls. It's really useful to see that data when we log in. iStumble have further developed their app, but I haven't seen the additional developments. Their app has the ability to send the care home a summary via email of the fall and if the resident was actually admitted into hospital or not. Next slide, please. So this is the EHCH update for November 2023, specifically under falls and falls prevention, and I've highlighted those bits that are really relevant to this. So how to get a person who's fallen from the floor, how to use the mechanical lifting aids. Care homes have access to the post-fall assessment tools, and they've specifically mentioned iStumble and Helpful and the mechanical lifting aids. So that was really helpful to us as we were going through our project. Thank you. Next slide, please. So finances. These are just some of the costs that we incurred as we were going through the project. I just need to make it clear that there was zero cost to the care homes. We supplied the lifting equipment for free for them, so their cost was zero. I'll just let you read that for 1 minute. Okay, thank you. Can I have the next slide, please? So these were the intended financial outcomes as at January 2023. So the assumptions, which were based upon a similar pilot from Mid and South Essex, 45% of call-outs were avoided. This is research. The cost of ambulance call-outs, £250 and per call out, and again, just to ensure that you're aware, it's 2022 to 2023 costings. The average cost of an ED attendance, £170. Admissions for Cambridgeshire and Peterborough CCG at the time, £2,525. And down the bottom you can see that the calculations, this was for the initial 10 care homes, that we were hoping to save £37,397. Next slide, please. This is some of the care home feedback, and I've got buckets and buckets of care home feedback. The question here was, has the lifting equipment benefited your residents? And 100% of them said yes, it had. So research shows, this is Cardiff University research, that 45% of fallers in care homes are uninjured and do not require transportation into hospital. 45%, as we've mentioned earlier, of admissions can be avoided, and the average cost of ED attendance for us is £170 per attendance. Next slide, please. I'm losing my voice. I can feel myself losing my voice, so sorry. Savings. This was data for 2022. There were 520 ambulance call-outs for falls into care homes during February to October 2022. And 169 of these fallers did not require an ED attendance, so 33% of them did not need to be conveyed. I've picked out ambulance ED attendances rather than call outs, and the reason that I've done that, I couldn't show a saving on the ambulance call outs, and the reason that I couldn't show a saving on the call outs is because some of our homes have a corporate policy that states that the staff must call an ambulance for medical reasons. So I was finding it really difficult to find that saving. However, I could see a difference in the ED attendances. So could I have the next slide, please? So this is the 2023 data. There are actually a higher number of call outs. There's 781 call outs for February to October 2023. 324 of them didn't require ED attendance. So our saving was £55,080 because 42% of them did not need to be conveyed. Next slide, please. So our intended outcomes, non-financial, reduction in the number of non-conveyed ambulance call-outs, care home staff make safe and effective assessments for injury after the resident falls. Residents who have fallen without injuring themselves can be assisted by the care home staff without the emergency services having to be involved. Enable care home staff to safely pick up the resident using the appropriate lifting equipment. Care staff are trained in an easy, non-distressing way to assess and lift the fallen residents with portable equipment and ensuring that people have a positive experience of care. And the next slide, please. So feedback. Care homes were asked, do your staff still use the equipment for the majority of falls? And 87% of them said yes. Do you think the resident would have the same outcome if you didn't have the lifting equipment? 91% of them said no, they wouldn't have that same experience and outcome. Next slide, please. Again, more feedback. I'll let you read through it. Bullet point 3 is really interesting. Stopped a long lie on the floor waiting for the paramedics. And the fifth and last bullet point, helped the resident up with the paramedics. They were very impressed. We liked that one. And the next slide, please. Sorry. Resident voice. Important to hear the resident's voice. Residents love using the razor. It's less messing around. The equipment doesn't scare the residents. It's easy to use and comfortable. Some residents have preferred to use the chair rather than the hoist. I've got a funny little story alongside this. One of the residents had seen one of her other residents in the care home being lifted up with the chair and asked if she could have a go. And they said, no, this resident has fallen, you can't have a go. 10 minutes later, they found her on the floor in her bedroom. She'd purposely fallen, got herself on the floor because she wanted to be lifted with the lifting equipment to try it out. Next slide, please. So our conclusion, the introduction of the lifting chairs supported by the apps has improved the quality of care. The care staff utilising the equipment found it user-friendly and effective. The care home staff have gained confidence, especially when using the app. The pilot has demonstrated savings relating to ED attendances amounting to £55,080 over the 9-month trial period. We have a competencies doc which we have designed with fail gains, and that is for competencies that are signed off after their training, and the lifting equipment has had a positive impact on residents. And that is the end of my presentation. Thank you. Excuse the voice.
Thanks both, that's excellent. Really good to see it in action, hearing it from some of the customers. Be good once we circulate the email to also maybe include some of the video feedback as well that we've got, Vicky, wouldn't it? In terms of the care homes and the residents talking about the impact it's had. That's really what we're here for, isn't it? The quality of care and making sure that they get the care in the correct time. So just, I'm very conscious of time. We're running over. I think probably we'll carry on as planned, and if anyone needs to jump off, that's fine, because the recording will carry on and will be circulated afterwards. So I just wanted to quickly touch on, if we're able to have the next slide, something that was mentioned in terms of the helpful dashboard that the likes of Cambridgeshire are able to access. So this is just a screenshot. So every care home, every carer, every time somebody's fallen, they will scan or use helpful to assess if it's safe to lift. Now that data is then accessible via a dashboard back to the ICB or whoever needs to see it, to then see which homes are actively involved, how many of different categories of falls are happening, and then some predicted cost savings, which we work through with the ICB to figure out what data we're going to plug into that calculation. Just hop onto the next slide as well. With each one of those falls, and this would be particularly interesting for somebody like Doug as part of that MDT team, to be able to identify each one of those falls, what's the cause of the fall, actions taken to then drive that prevention work as well. So that's some live data there. If we stop the PowerPoint now, obviously we can go into more detail after this with just like specific demonstrations and whatever's required, but I just thought it makes sense for us to do a brief demonstration with the razor chair. Now I've got a colleague off camera who, if anyone's joined a webinar before, probably familiar with him having our fall for us. So if I just get Andrew to join, hopefully you can see this. Hopefully you can still see that, so you can see some floor space there. So Andrew, if you have your fall there, I'll maybe a bit more in the centre. So I'm going to keep this fairly brief just so that you get the principle of it. The razor comes in two packages. It's got a backpack and then a seat unit. I appreciate that residents don't fall in wide open spaces like this, but the principle is you move them into a position where you're then able to use the chair. So seat unit here, this is where the main battery is housed, and the lifting components are in this backpack here. So I'm just going to build this or assemble it around Andrew, encourage them to bend their knees. Then we're going to slide the seat unit underneath, keep the thumb up against their thighs. And then in here, we've got the different lifting components. So you've got two back rests and then some 4 of these curved legs. Now, this would be, we would have used helpful to check Andrew to assess that he's safe to lift. If that and we are feeling comfortable that it's safe to go ahead, we then use the razor chair. So encourage residents to cross their arms and roll away from you slightly. And then we're just going to pop that backrest in. And then same again on this side. Let's assume that maybe we haven't actually got access to the other side. Let's fall into the bath or something. And I'll place that there initially. Roll Andrew forward a little. And each time we put it in, it's giving us a confirmation to say that it's correctly assembled. Reassurance with the safety belt, and then these lifting arms just pop into place. You physically can't assemble it incorrectly, it won't work until it is registered that all the parts are assembled. And we've got the last one in, slightly different noise, it's gone green. We'll get the remote control, which is actually housed in the seat unit. And then we're just going to simply press and hold the up arrow and support the resident's head. Like so. Now, depending on the height of the resident, you can obviously stop it at varying points. But we'll keep going just to demonstrate how far it can go. Keep going into the vertical position. Stop at its most upright position. There we are. And then in this position, then maybe with a standing aid or walking frame, we can then support the residents to mobilise from that position. Now, that's a really high-level demonstration. More product information can be shared in due course, but I guess the principle is it's a one-person operation. It's quick. It's really dignified for that resident, rather than having to swing around in a hoist and have to fear ever ending up on the floor. As Vicky mentioned, sometimes residents will actually end up putting themselves on the floor merely for the experience of being lifted back up again, which is a little bit counterproductive, but there we are. So I must confess, I haven't been keeping too close an eye on the Q&As, so be led by the panel as to which ones need picking out. I don't think there's going to be time to answer all of them, but I don't know if any of you on the panel have got any ones that you specifically want to answer live.
I've answered in the chat, Grant, thank you, that there was a question there about costs for the use of the apps. Debbie Parker was asking, so that's probably one for you.
Yeah, good. So you're right. So there's as Vicky pointed out, there's kind of two options with the apps. You've got the iStumble, which is for the inflatable cushions, and then Helpful, which is for the razor chair. iStumble is free. Helpful is a paid model, £19 per month for an access code. So that's for each care home. But what that will also give you is access to that central dashboard, which I mentioned earlier, and that high-level data. It's then really useful in terms of driving that prevention work. Obviously, you can share more details in due course. Just trying to pick out any others there.
I think the others were answered, Grant, as we've gone through. I just had a question though, if you don't mind. Just occurred when you were using the chair there. If you've got somebody that's agitated and they're not hurt, but you help them to stand, if you're, I guess the concern is if you're by yourself, is there a danger when you get to almost standing point, they might try and get out of the chair and fall with the chair still attached to them?
I don't know of the correct way to answer your question, short of demonstrating. So if somebody, obviously you need to risk assess each situation, but let's say you start a vehicle family who've got really anxious, you can obviously lower them back down to the ground, but the razor chair is stable enough to cope with a fair amount of involuntary movement, including like leaning forward as far as you can. So actually getting the thing to tip over is quite a challenge. Obviously, if you've got more than one carer on hand to be able to provide reassurance, definitely recommend it. But in those circumstances where it's just the one of you, it's possible.
That's really helpful. Thank you for sharing that.
Wouldn't exactly recommend that residents do that, but that's the principle of it. Okay, look, I will go through the questions that have come up in the chat and the Q&As after the session. If there's any that I don't feel have been answered, the panel here have also agreed to have their contact details shared to specific ones if needing further information. But after this session, we'll pull this together into a video. We'll share the slides. Everybody that's attended will get both the recording and also the slides. But I do believe that brings us to the end. I hope that as coming, you can see some of this framework actually brought to life in terms of real projects. The policy is great in the sense that it gives us some outlines. What we thought was really helpful is let's get some of these partners across the country that actually have implemented this already, and let's share that best practice. Now, obviously, happy to keep in touch. We'll send the email around. I do believe that's done, unless the panel have got anything else to say.
No, thanks.
No, thank you.
Okay, thank you very much for joining all. We will keep in touch.